So why do we treat vascular tumours by embolization techniques? Maybe to control shunts, reduce tumour bleeding, because they can bleed sometimes, to sometimes improve platelet counts. But I told you in KHE they don't have shunts. So I'm not going to focus on this right now because these are not high-flow vascular tumours. These are hypervascular vascular tumours. You may want to promote tumour involution and reduce tumour vascularity if the surgeon wants to resect these. We commonly use PVA if the vascular morphology is suitable. If it's adverse and the shunting is so significant, then without question we use glue, and I really use glue lots now, more than PVA. Sometimes we use coils. I haven't taken myself to use any other occlusion agents like Amplatzers in these situations. And the technique depends on the amount of vascularity and shunting in the morphology. So we really need to understand what we're dealing with. And I showed you this example before of this Riche in this baby's arm and with this rapid shunting. And what I want to do is just briefly show you the embolization using just PVA. And this was the angiogram before. This is the catheter, it's a 4 French Berenstein, advanced slightly further with a micro through it. And in fact, we're going to embolize this with some PVA around about 350 size. And then the microcatheter shows slightly more reduction in the flow. And then the final angiogram, although it doesn't completely show devascularization, has actually reduced a lot of the hypervascularity and the shunts. And in fact, this baby did stop bleeding after this. So even with PVA, you can actually provide good control. This will involute in time on its own because it is a Riche. So we're actually just providing a useful adjunct to get the baby through a difficult time. So I use glue a lot, and this was just one example actually of a niche. And this was a rare niche where there was, it wasn't the flat typical appearance, it was a slight expansion in the distal forearm. And this girl needed some surgery, so we decided, you can see how hypervascular this is, with parenchymal staining, enlarged vessels. And we really wanted to devascularize this before surgery, and so we actually did some selective glue embolizations and just used some microcatheters to get out into some of the feeders, not to completely close the lesion, but to reduce its hypervascularity, to make it much easier for the plastic surgeon to remove this. And she's had this removed, and the plastic surgeon, I see him several times a week, and he told me how easy the removal was, and the girl's been absolutely fine. So glue can be really easy and quick to use. This was the lesion before we glued it. We didn't completely reduce it, and maybe I always think, oh, I'd like to reduce it a little bit more, but you know, there's always a trade-off, and the surgeon was completely happy. He actually operated on this. Actually, it was about 4 weeks later. If we're using PVA for lesions, we like them to try and do surgery if they are going to within a few days, usually by 5 days maximum. But glue, you've got a longer window, a much longer window. So after embolization, like after sclerotherapy, we always, and treatment flow vascular anomalies, we always must monitor the patient, depending obviously on their condition, whether they're on our ICU intensive care unit or not. If they have pain, hydrate them well with double maintenance, because if you're injecting alcohol, they can get hemoglobinuria, like the venous malformations can. We always carefully monitor the urine volume and color. If the child has a Foley, and often the smaller children will have Foleys in, put them in when the child has had the general anesthetic, not beforehand, and they are left in for a minimum of 4 hours afterwards. And obviously we want to really reassess the lesion and look at the patient and make sure the patient is okay after we've finished. So there are risks of arteriovenous malformation embolization, like with sclerotherapy of low flow malformations and venous. Risks related to the embolic agent. We can derange the coagulation, the procedure itself, inadvertent embolizations, and actually always beware of shunts like patent foramen ovales in neonates. And tissue injury can be significant. You can get ulceration, and ulceration actually does take months and months and months to heal. And I think I'd really like to stop on this slide just to give an overview of managing high flow vascular anomalies and not just vascular malformations. In children, there is no quick fix for an arteriovenous malformation. They often need repetitive treatments and embolizations. Occasionally you can combine embolization and surgery, and I have had patients who've had several embolization treatments and gone on and had surgery and have done quite well. Usually we cannot cure. We're not in the game to cure, we're in the game to control. There are high risks with AVM treatments. Don't forget, for arteriovenous malformations, the simpler ones we can certainly cure. You don't need to wait, you can go on and treat them. And for vascular tumours, don't forget you were doing the embolization to close the shunt and to reduce the vascularity, but the children actually need help with angiogenesis inhibitors as well. And so you must work as a team all together to really get good outcomes from your procedures. Thank you.
Thank you so much, sir. It's an absolute pleasure to listen to you. Your quick tip list and innovations in combining techniques will sure serve as a guide in approaching these anomalies. We now go on to the next lecture, which is again by Dr. Phillip John, which is on complex vascular anomalies.
So, for those of you who've not been to Toronto, even coming from the United Kingdom, I used to think that Canada was buried in snow most of the year. And it's a misconception, really, because Canada does have hot summers and long hot summers. They can be very sticky, but they can be really enjoyable. And Toronto is actually geographically located on Lake Ontario. And we have beaches, believe it or not, on the lake. The summers are long and hot. You can actually swim in the lake. The lake is now clean. This is downtown. We have ferries taking us. We have a series of islands which only take 5 minutes by ferry to get to. And we have lots of boating activities and water activities in the summer. So it's really a very nice city, and it's a really good location. So we're not always buried in snow. So what I really wanted to, and what Matthew asked me to talk about now, was about the complex combined vascular malformations, and really to focus on one condition, which is the Klippel-Trenaunay syndrome, and how you can differentiate this from Parkes-Weber syndrome as well. And I'm not going to talk about many of the other complex combined vascular malformations, just predominantly Klippel-Trenaunay syndrome and a little bit on Parkes-Weber. So these come under the group of complex, in this classification, these come under the group of complex combined vascular malformations. Klippel-Trenaunay syndrome, or it used to be named, or sometimes is, and perhaps incorrectly, the Klippel-Trenaunay-Weber syndrome. It really is the Klippel-Trenaunay syndrome. When you go back, if you're being very pedantic and correct, it's the Klippel-Trenaunay syndrome, or KTS. It's a combination of capillary, lymphatic, and venous malformation associated with overgrowth, or CLVM for short. In this condition, there are a triad of clinical features. The diagnosis of KTS is clinical. You don't need any scans. And the triad of clinical features in order to make the diagnosis of KTS is a cutaneous capillary malformation, which is present in nearly all the patients. So the cutaneous capillary malformation, like the ones I showed you on the face on those two children, is otherwise known as a port wine stain. So, for example, in this boy with KTS affecting his leg, here is his port wine stain, or his capillary malformation. The second clinical feature is soft tissue and bone hypertrophy, which is present in about 2/3 of patients. So you may have enlargement of one leg. For example, it may be longer in length or larger in girth, or both. And also the presence of varicose veins, or varicosities, and sometimes venous malformations, which are present in over 2/3 of patients.